Hello, everyone, and welcome to the final Cardio LAN of 2018. We'd like to thank you for joining us today and taking the time, whether you are listening to the archive recording or whether you're watching and participating in the live event. We'd like to thank you for that. Now, before we get started, we have a few announcements or housekeeping items. Today's webinar is being recorded. All participant lines are currently muted and will remain so throughout today's session. We encourage you to submit questions and comments through the Q&A feature on the right side of your screen. If you're not seeing this feature, you may need to click on the icon in the upper right-hand corner to activate it. We'll get to as many Q&As as possible during our time together today, but if you have questions after the live event, please submit them to hhqi at hhqi@qualityinsights.org, and that address is located on the final slide. Today's session has been approved for 1.25 nursing fees, and it's available through the HHQI University. Following watching this webinar, we'll ask that you complete a very short evaluation and reflective question just to get those 1.25 nursing hours. Today's session has been approved by the Alabama State Nurses Association. The ASNA is an accredited approver of nursing continuing education through the American Nurses Credentialing Centers and Commission on Accreditation, or the ANCC, and is accepted in all 50 states. After today's webinar, we hope that you will be able to explain how air quality impacts cardiovascular health and premature mortality. We hope that you're going to be able to identify EPA tools and resources available for healthcare professionals to help at-risk patients avoid exposure to air pollution and, air particle pollution. And we also hope that you're going to be able to describe the Million Hearts Initiative and how it has incorporated EPA tools and resources to reduce air pollution exposure and prevent heart attacks and strokes. Now it is with great pleasure that I take a moment to introduce you to Dr. Wayne Cascio. Dr. Cascio earned a BA from Johns Hopkins University and an MD from the University of Maryland. He completed his clinical training in internal medicine and cardiovascular diseases at the University of North Carolina and postdoctoral training in basic electrophysiology and pharmacology at the Physiologische Institut Universität in Bern, Switzerland. Prior to joining the EPA in 2011, Dr. Cascio worked to increase access to cardiovascular health care in the underserved rural areas while Chief of Cardiology at the Brody School of Medicine at East Carolina University, and served on EPA's Clean Air Scientific Advisory Committee for particulate matter. He now serves on the EPA's liaison to the CDC National Center for Environmental Health, Agency for Toxic Substance and Disease Registries Board of Scientific Counselors, and the Institute of Medicine's Roundtable on Environmental Health Sciences, Research, and Medicine. Dr. Cascio has authored and co-authored more than 185 journal articles and book chapters. He is the recipient of the 2013 EPA Gold Medal for Exceptional Service, a 2013 Office for Research and Development Impact Award, and numerous scientific and technological achievement awards. Current research includes the study of health effects of environmental pollutants, especially wildland fire, smoke, to inform risk assessment, risk management decisions, and improvement of public health and quality of life through increased environmental health communication and literacy. Dr. Cascio is a clinician, scientist, and is board certified by the American Board of Internal Medicine in Internal Medicine and Cardiovascular Diseases. Dr. Cascio has spent more than 25 years as a cardiologist helping people take care of their hearts. And now he is bringing a broader view of public health to EPA by leading research on the links between exposure of air pollution and maintaining a healthy heart. Please join me in welcoming Dr. Wayne Cascio. Dr. Wayne Cascio, the floor is yours.
Well, thank you so much, and good afternoon to everyone who's on the call today. And thanks so much for this opportunity to share some important information describing the effects of air pollution on cardiovascular health. And it's my hope that this information will be relevant to many of home health professionals as you manage your patients. Next slide. So in the first few slides, I'll review air pollution and some definitions so that we're really on the same page. As you can see in this cartoon, common air pollutants are produced by natural, stationary, and mobile sources. Primary pollutants include carbon monoxide, nitrogen oxides, sulfur dioxide, and suspended particles. Secondary air pollutants form in the atmosphere by chemical reactions. Ozone is a common secondary pollutant important to human health. Next slide. For this presentation, the focus will be on particulate matter, or as it's often abbreviated, PM. Particles are defined based on their size. Particles that behave like spheres of 2.5 microns in diameter are called PM2.5, or fine particulate matter. And you see those illustrated in the image on the left as red spheres. PM less than 10 microns are called PM10, and they're illustrated by the blue spheres, and you can see them in a chain going across what is intended to be a human hair, just to get to some idea of what those are like. And their relevance is that any particle below PM10 or 10 microns will go all the way through the respiratory tract into the alveoli. The Clean Air Act requires that each of these be regulated. For PM2.5, the National Ambient Air Quality Standard is 35 micrograms per cubic meter when averaged over 24 hours, and it's 12 micrograms per cubic meter when averaged over an entire year. However, as the scanning electron micrograph shows on the right-hand side down there in the corner, we see that ambient airborne particulate matter is very heterogeneous and composed of aggregates of even smaller particles. Next slide. So the next two slides will address the scale of the public health and clinical impact of ambient air particle pollution. Next slide. This slide shows measures of global air quality on a single day and highlights the high level of air pollution in Asia, the Middle East, Central Europe, and our West Coast, as indicated by the red and purple colors. So those are all individual measurements made throughout the world. And that's fairly typical of an average day in many parts of the world. Next slide. Now, air pollution is a leading cause of global disease burden. In 2015, exposure to PM2.5 was ranked 5th as a risk for mortality. It's estimated that PM2.5 caused over 4 million deaths and around 100 million disability-adjusted life years. Importantly, deaths attributed to PM2.5 increased from 3.5 million in 1990 to over 4 million in 2015. Also, while this talk really focuses on particulate matter, exposure to ozone caused an additional 250,000 deaths and a loss of 4 million disability-adjusted life years from COPD alone. Next slide. The U.S. has enjoyed much better air quality than other parts of the world for decades. So the question arises, do we still need to be concerned about air quality and cardiovascular health in our country? Next slide. These two plots highlight the overall improvement in air quality in the U.S. from 2000 to 2017. The dashed lines that you see show the concentration of the national standards for PM on the left and ozone on the right. As you can see, the average annual average PM2.5 and ozone concentration in the U.S. now falls below the national standard, which is a great thing. This improvement has translated into improved health and longevity. Next slide. This point is illustrated in the map of the U.S. in the upper left-hand corner. showing the fraction of total deaths attributed to PM2.5 in the U.S. In 1980. In some of these areas, and you can see those on the West Coast and in the East, up to 13% of all deaths were attributed to PM2.5. Compare these numbers to 2010 in the map below, where we see these rates reduced by half or more. So we've made substantial improvements. Next slide. Yet despite this improvement, air pollution remains a significant U.S. public health concern. The excess U.S. mortality from PM2.5 is still estimated to be about 120 to 125,000 deaths per year. Other social burdens, including over 20 million school days and work days lost, and over 1 million life years lost. In 2016, nearly 120 million people were still living in counties with one or more of the criteria pollutants exceeding the national ambient air quality standards set by the EPA. Next slide. While PM2.5 continues to decrease in many areas of the U.S., PM2.5 is rising in wildfire-prone areas, as shown by the red and orange regions in the Northwest in this map of the U.S. So those areas in the West are where you see the large wildfires, and they're contributing a substantial amount of particulate matter. Next slide. So what do we know about cardiovascular health effects related to exposure to air particle pollution? Next slide. Before we get there, let me just show you sort of what happens to particulate matter in the atmosphere over time, just day by day. This slide shows daily changes in PM levels over several months in Chapel Hill, North Carolina. What I'll point out is that the transient increases in daily particulate matter levels, as indicated by the red and green bars, and by the blue arrow showing that transient increase over several days, are associated with short-term clinical events, whereas the overall average level of particulate matter, which you could estimate by just averaging all of those columns, and it's illustrated by the yellow bar, is associated with long-term clinical events. So there are two things happening here. There are these transient increases from day to day that are associated with short-term clinical conditions, and then there's the long-term effects of higher levels of particulate matter. Next slide. There have been two important initial publications that kind of set the stage for our understanding of the association between particulate matter exposure and heart disease. And these were the American Heart Association scientific statement published in 2004, which I was one of the co-authors, and EPA's 2009 Integrated Scientific Assessment. Next slide. The American Heart Association updated the original scientific statement on particulate matter and cardiovascular disease in 2009. And I've just copied and pasted just the front page from that. This paper summarized the key associations between air particle pollution and cardiovascular disease for the healthcare community. The message was that short-term air pollutant exposure triggered heart attacks, strokes, heart rhythm disturbances, and worsened heart failure. The paper made the point that it would be prudent for healthcare professionals to advise patients with heart disease to reduce their exposure to air particle pollution when levels are high. Next slide. 2012, the EPA published, and this is the title, The Provisional Assessment of Recent Studies on Health Effects of PM Exposure. The document summarized more evidence that it accumulated that showed that long-term air pollutant exposure contributed to cardiovascular morbidity and mortality and was associated with high blood pressure and ischemic heart disease and stroke. Next slide. In October of this year, the EPA released the Integrated Science Assessment for Particulate Matter for external review by the public. This is now available online on the EPA's website. The conclusion remains unchanged. Air particle pollution is causally associated with cardiovascular health effects and mortality. Next slide. So we know that air particle pollution has health effects, and in particular, cardiovascular health effects. But what do we know about the dose response of air particle pollution to these health effects? Recent research has now better defined that relationship, especially for lower concentrations. Estimates of short-term particulate matter at 2.5 levels is associate, and its association with mortality risks are shown for a U.S. Medicare population in the figure on the left. So there you see on the y-axis the relative risk increase in mortality as a percent, and on the x-axis the PM2.5 concentration in micrograms per cubic meter. As you can see, the relative risk of death increases steeply for changes in PM2.5. The risk plateaus at about 20 micrograms per cubic meter. Now, this is for short term. Now, remember, the EPA's National Ambient Air Quality Standard is 35. These risks translate into about 1.42 excess deaths per 1 million people for each 10 microgram per cubic meter increase in PM2.5. So we now have pretty good evidence with strong, narrow confidence intervals that this is about what we can see in terms of an effect. Next slide. Switching to estimates of short-term mortality related to ozone, we see that the risks shown for the U.S. Medicare population in the figure again on the left. And like with PM, we see an increase in risk of mortality as the ozone level increases. But in contrast to the PM, the confidence intervals at low levels are very, very broad. And so there's a great deal of uncertainty there. However, the plateau in this particular study does occur at about 60 parts per billion. These risks translate into about a 0.066 excess deaths per 1 million people for each 10 part per billion increase in ozone. Next slide. Now, the two figures on the left are part of a study that we did to better understand the relationship between long-term exposure to PM2.5 and the presence of coronary artery disease. We studied a cohort of individuals who underwent coronary artery angiography at Duke University and who resided in North Carolina. So this was a partnership between investigators at the Duke University Medical Center and our group at the EPA. We found that for a 1 microgram per cubic meter increase in the annual average PM2.5 level, we saw a 11% relative increase in the likelihood of significant coronary artery disease and a 14% increase in the odds of having had a heart attack during the previous year. A very similar study was conducted at the Cleveland Clinic in their clinical population, and they found almost exactly the same result. You see those results there on the bottom right. So for each 1 microgram per cubic meter increase in annual PM2.5, they saw a 17% relative increase in coronary disease and a 24% increase in more severe, that is 3-vessel disease. They saw exactly the same percent increase in having had a heart attack within 3 years. Next slide. Now, estimates of long-term mortality risks are shown in the figure to the left related to PM2.5. As you can see, as PM2.5 concentrations increase, the percent of effect actually diminishes a little bit. The outcome of these studies show that the risk is about 1.29% for every 1 microgram per cubic meter increase in PM2.5 above the level of 10 micrograms per cubic meter. So said another way, if you start at a background of 10 micrograms per cubic meter and you increase the PM level annually for 1 microgram per cubic meter, you'll get about a 1.29% change in mortality. If you go up further, you continue to build on that, but the amount of risk actually diminishes the higher you go. Next slide. So who is at risk from exposure to air particle pollution? Next slide. Many epidemiologic studies have identified the populations who are at greatest risk from air particle pollution. Susceptible adult populations include, and this is, I think, very relevant to your population, those with pre-existing cardiovascular disease and respiratory disease, older adults, but also children and the developing fetus, and those who live in areas of lower socioeconomic status. We also suspect that other populations may be at greater risk too, and these are people who would have chronic inflammatory diseases, for example, diabetes, hypertension, or obesity. Next slide. Now, I pulled together this series of recent studies, so these were just pulled from the literature, to show that the risk to individuals who've survived a myocardial infarction is much higher than that of the general population, because the risk in the general population, as I was pointing out, is maybe 1.5%. But among people who've already had an event, so they've declared themselves to be at a higher risk for cardiovascular disease, their risks are anywhere from 25 to 50% higher. So these are substantially different and represent a higher, much higher risk group. And this is what got the attention of Million Hearts. Next slide. So, are the cardiovascular health effects present in epidemiologic studies biologically plausible? And this is where the story begins to get interesting. Now, a practical way to look at how air particle pollution might increase cardiovascular risk is to look at how exposure modifies the well-established cardiovascular risk factors. So here I've placed a screenshot of the atherosclerotic cardiovascular disease risk estimator that's provided by the American College of Cardiology on the left side of the slide. And on the right, we see how air pollution modifies each of these risk factors, and that's all based on literature. Air particle pollution advances aging by shortening telomeres. It increases cholesterol and oxidized low-density lipoprotein, as you know to be the more atherogenic lipoprotein. It raises blood pressure, and it decreases high-density lipoprotein particle number, so it decreases the protective lipoprotein. There's also evidence that ozone might contribute to diabetes, and interestingly, there is some evidence that statins might be protective. Next slide. However, the most direct evidence that air particle pollution is likely to cause coronary artery disease is what we call the multi-ethnic study of atherosclerosis air pollution study. This was a study funded by the NIH and the EPA. The EPA contributed about $30 million to the study, and it lasted for 10 years. This slide provides a short summary of the key findings of what we call the MESA Air study, which used coronary calcium scoring as a measure of atherosclerosis in relationship to long-term exposure to PM2.5 and also nitrogen oxides. These findings were published in the Lancet journal in 2016. The take-home message is that long-term PM2.5 and nitrogen dioxide increased coronary calcium, which is an indicator of atherosclerosis. The panel on the left shows the relationship between the different air pollutants and the associated increase in coronary artery calcium each year. So it's increasing PM2.5 by about 4% for a change of 5 micrograms per cubic meter, and about the same for nitrogen oxides at 40 parts per billion. The panel on the right provides more detail showing the overall rate of coronary artery calcium accumulation per year as annual PM2.5 levels rose. And you can see the various areas in the country where the patients were recruited. So there were 6 areas: North Carolina, there was Central North Carolina, New York, Maryland, Minnesota, Illinois, and California. And so at lower levels, you get less accumulation; at higher levels, more accumulation. Next slide. This slide illustrates the MESA Air coronary artery calcium accumulation in a slightly different way. And coronary calcium is measured in something called Agassiz units. These are a well-established approach to quantifying calcium in coronary arteries using very high-resolution CAT scanning of the chest and heart. Here we see the magnitude of the absolute coronary artery calcium level over 10 years at 3 different annual PM levels. For the sake of argument, chosen 10, 15, and 20 micrograms per cubic meter. The projected difference in calcium, coronary calcium, clearly is influenced by the annual level of PM2.5. Compare, for example, the magnitude of the change in coronary artery calcium between an area with annual ambient PM2.5 of 10, which is shown by the yellow line, and 20, shown by the red line. So that's, from a clinical perspective, that is a pretty significant change in calcium. And remember, calcium levels in the coronary arteries relate to coronary artery risk. Next slide. So apart from the pulmonary and cardiac health effects, I wanted just to point out that the epidemiology literature is also pointing us to additional effects and giving us new insights into other clinical conditions as well. And these include neurodegenerative disorders, anxiety, depression, and cognitive function, like dementia. Also, there's also an increased interest in looking at neurotoxicity in children and also the acceleration of aging. Next slide. Other health effects have also been observed and are under study and are worth mentioning. Air particle pollution has been associated with infertility, fetal growth, including preterm delivery and low birth weight, stillbirths, and biological aging, as I mentioned, although these effects require further study. Next slide. So now I hope that one would appreciate that air pollution adversely affects health, longevity, healthcare resource utilization, and public welfare, for example, visibility and effects on vegetation and ecosystems. Yet most healthcare professionals and patients at risk, while many of them know about the pulmonary effects, very few know about cardiovascular effects. And while pulmonary physicians will often take time to educate their patients, few healthcare professionals are spending any time with people with heart disease to reduce their exposures and hopefully improve their outcomes. Next slide. So what can the healthcare community do to reduce the adverse impacts of air pollution? Let's go to the next one. In this slide, we see that this message is again reiterated in the European Heart Journal 5 years after the 2009 American Heart Association paper. The authors concluded that, quote, air pollution should be viewed as one of several major modifiable risk factors in the prevention and management of cardiovascular disease, and that, quote, health professionals, including cardiologists, have an important role to play in supporting educational and policy initiatives as well as counseling their patients. Next slide. In the U.S., services to improve and maintain health are provided by the healthcare system, as shown on the right, and the public healthcare system, shown on the left. We don't typically think of the EPA as a public health organization, yet we are. The National Ambient Air Quality Standards for air pollutants serves as a primary and secondary preventive measure. However, with respect to the traditional clinical prevention, it generally requires evidence-based studies to justify those interventions. And at the present time, there are no controlled randomized clinical trials that have been done to test whether interventions to lower PM and show reduced clinical events. Although face mask trials have been done and show short-term improvement in biological measures, for example, systemic inflammation, we still don't have any studies that have been done to ask the question, does reducing air pollutants in one's home decrease the occurrence of heart attacks? We know that improving the overall air quality in a region of the country or in a city has benefits, but what about in somebody's house? Yet the epidemiologic evidence of the health effects of PM is so strong among the most vulnerable, it's prudent to advise reduced exposures. And there actually have been some modeling studies that suggest that it would be economically beneficial to put in HEPA filters in homes of high-risk people. This advice has been incorporated into the joint CMS-CDC Million Hearts Initiative as an innovative clinical prevention program by combining EPA's Healthy Heart Program and its health information with that of Million Hearts. Next slide. This slide is kind of an aggregate of all the products that EPA now has to educate healthcare professionals about the relationship between air pollution and cardiovascular health. And you can see there it includes fact sheets, which you can download from the AirNow website, as well as a CME course for healthcare professionals, and I'll tell you a little bit more about that. Next slide. One of the best sources of up-to-date information about air quality and its impacts on air and health is the AirNow website. that the EPA's Office of Air and Radiation supports in collaboration with the states. Apart from the air quality information, the website offers educational material for the public and healthcare providers. The website was recently updated with a new look and more mobile-friendly website. It still has the same great information and better displays temporal changes in air quality. Now, I will add that because of the Camp Fire in out west in November, the use of the air now was so great that it crashed the system, and they've gone back to the old one, but we look forward to getting the new one up and running again within the month. Next slide. Most everybody's familiar with the color scheme of the air quality index, ranging from good, which is shown by green, to red, indicating unhealthy, to brown, which is hazardous. Each level carries with it a cautionary statement providing recommendations for those at risk to reduce exposure. Next slide. So in this slide, we see the National Air Quality Map that highlights local air quality as well as forecasts. And forecasts can be particularly helpful in guiding what one might want to do the next day. Next slide. The Healthy Heart Program is something I developed when I came to the EPA in collaboration with my colleagues to raise awareness about the role of outdoor air pollution in cardiovascular health and to inform the public of actions they can take to reduce air pollution exposures. Next slide. The Healthy Heart Toolkit and Research is a web portal that directs the viewer to a wide variety of health information associated with air particle pollution and cardiovascular health. Next slide. I mentioned this earlier, and EPA is partnering with the joint CDC and CMS's Million Hearts initiative. Million Hearts, I think as you all know, has a goal to reduce heart attacks and strokes by 1 million over the next 5 years by keeping people healthy, optimizing their care, and addressing health equity in priority populations. EPA is contributing the Healthy Heart Program to lower air pollution exposures in at-risk populations in an effort to decrease heart attacks and strokes and improve vascular disease outcomes, to decrease disability and healthcare expenditures, and to decrease the societal burden of vascular disease. Next slide. Million Hearts is also recommending conveying information about engaging in the healthy heart behaviors, which include air particle pollution, to patients and family supports as part of their optimizing care instructions, which are shown here. So you can see now risk for particle pollution is included as it's considered something that a high performer would do as part of an effective healthcare strategy. Next slide. The Million Hearts Initiative has set as a goal improving outcomes for priority populations. One priority population includes people who have had a heart attack or stroke. Million Hearts has included a recommendation for such individuals to avoid exposure to PM as shown in the circled area. Next slide. Million Hearts also provides a large number of educational tools on particle pollution on their website. Many of these actually are drawn from EPA's materials, but it's a good spot to go if you want to learn more about particle pollution. Next slide. We've developed a continuing medical education course for healthcare professionals and health educators, and this includes nurses, and so it's called Particle Pollution in Your Patient's Health. It is located on the CDC's website, and they provide the continuing education credit for the course. It takes an hour and a half or so to do. And it's very informative. Just to go to the next slide, and I'll just show you a couple of screenshots of the different chapters which are there, including what is particle pollution, Particle pollution exposure is another chapter. Next slide. Particle pollution and cardiovascular effects. And then there's also a whole section on clinical scenarios where we present various cases where exposure to air particle pollution is a relevant consideration in the management of that individual. Now, air pollution varies tremendously over space and time. And new studies using amazing technologies, particularly with mobile sensors, are really demonstrating this fact. And I'm just showing you one example. This was a study that was done in cooperation with Google, where the cars that drive around cities and take pictures for their maps also contained the instrumentation to measure a variety of air pollutants. And what you see on the slide on the right is a map of Oakland, California, showing the spatial distribution of black carbon on the roads. As you can see, the concentration, which is indicated by the darkest black or red, is highest on the roads and in that near road environment, and is obviously a function of the traffic. So a practical outcome of this work is that it provides a visual representation emphasizing that if one wants to reduce their exposures, they should spend less time where air pollution is bad, like roads. And that if we're making decisions about where to spend our time or where to exercise, one should spend that away from the heavy traffic. The good news is that you can see by the map, you don't have to get far away from the traffic and have substantially lower levels of exposure. Maybe a block, maybe two. Next slide. As we consider new developments in the future, we see modeling studies suggesting that home high-efficiency particle filtration might mitigate the adverse health effects of air particles among older adults and those at risk. I mentioned this previously. This is the paper by William Fisk and Chan in Indoor Air in 2017. And the time's come for a randomized controlled trial to test the hypothesis that lowering exposures among those at highest risk, like those who've had a heart attack or who have had a stroke or heart failure, will benefit from home HEPA filtering and will improve clinical outcomes. Next slide. So in summary, particle pollution increases short and long-term cardiovascular morbidity and mortality, and is responsible for a high level of health burden on society. Older people and those with pre-existing heart disease and lung disease and diabetes are at higher risk. And the mechanisms are under investigation and are likely related to oxidative stress and inflammation and effects on the autonomic nervous system. Improvements in air pollution levels reduce health impacts and increase life expectancy. Next slide. High-risk patients should be educated about risks of air pollution and educated about measures to reduce exposure. Decreased short-term exposures in high-risk patients is predicted to mitigate adverse health effects in high-risk individuals. Randomized controlled trials are needed to provide to prove the effectiveness of interventions to reduce exposures. And health risks need to be addressed through integrated efforts of public health and health care at the community and individual level. More effective health communication strategies are needed to encourage health protective behaviors. And one thing we rarely really talk about is that one way to decrease the population burden related to air pollution is just make our population healthier. If we have fewer people with chronic conditions, they will tolerate the levels of air pollution better. But our agency continues to have the goal to help communities that are not meeting the National Ambient Air Quality Standard to do that, to protect their population. And with that, I'll close, and I thank you very much for your attention. It was a pleasure being able to provide the webinar, and if we have time, I'm happy to answer any questions. Thanks.
Well, thank you very much. We really appreciate that. I think that was a wonderful presentation on the application of the science and what we need to keep in mind when we're caring for our patients with cardiovascular issues. Now, for those of you that have any questions, we've been getting quite a few, and we thank you for those. Continue to go ahead and put them through the Q&A section if you'd like, or you can continue to send them to us through hhqi@qualityinsight.org, and we will get to as many as we can. The first two, they weren't together, but I kind of grouped them together because they're similar, is are there studies occurring or planned for wildfire areas, especially due to the expansive nature of fires occurring over the last 5 to 10 years? And the second question that was related to that is, are you seeing an increase in hospitalizations in the fire zones, or is it too soon?
No, we are seeing increased hospitalizations in the fire zones. And there are a number of studies that are now underway and some that are being drawn to a conclusion, looking at endpoints such as increased use of pharmacological agents for respiratory disease, for the use of emergency departments or urgent care centers, as well as hospitalizations themselves. At the EPA, we have a number of national studies, whereas most of the other studies I'm aware of are focused primarily on local events. Ironically, I was sharing with you earlier, I'm in Asheville at the International Association of Wildland Fire at organization's safety summit. So I've had an opportunity today to meet with representatives of the Centers for Disease Control and the U.S. Forest Service. And all of us are very motivated and to work collaboratively to try to get more information on the health effects of wildfire and to be able to provide insights on how we can better provide public health support during these events. So there are probably somewhere between 15 and 20 major questions that I get from public health officials and clinicians repeatedly, and so I've got that list, and we're going to see what we can do about getting answers to those questions. But it's something that the EPA's Office of Research and Development is clearly prioritizing, and we're putting more effort into trying to get some of these key questions answered. Thank you for the question.
Well, thank you for the information. Seems like a lot of these questions are similar. I guess we're all in the same boat. Next one is actually just mentioning the studies you mentioned show an increase in vessel disease with an annual increase in pollution. But do you know if there is a short-term risk as well?
Yeah, so yes, there are short-term risks and long-term risks. The study that I showed you, there were two studies that I mentioned, one from North Carolina and one from Ohio. Those related to long-term average exposures, and they corresponded to the progression of atherosclerosis as suggested by the Mesa Air study, using a different endpoint, which was calcium scoring. Now, short-term effects are things like heart attacks and strokes and worsening of heart failure and abnormal heart rhythms. So these are triggered events. It's not related to atherosclerosis suddenly getting worse, but instead an unstable plaque rupturing, causing a heart attack, or the autonomic system being perturbed to cause a heart rhythm disturbance. So it's a very different mechanism, but both occur. So short-term effects are effects that are measured in hours to a couple of days, 3-4 days. long-term effects, we're referring to generally in these epidemiology studies exposures that last a year or more.
Thank you for that. The next question is, has air pollution been studied in rural areas with pesticide usage and its effect on cardiovascular health?
I'm not aware of any study that has looked at multiple pollutants like air pollution plus pesticides.
Mm-hmm.
The health effects of PM has been studied in urban areas and rural areas, and we find that the effects are present in both areas. The nature of the particles may be somewhat different, but we still see health effects.
Oh, thank you. The next question is, and it's kind of a couple questions that align together, so if it's okay with you, I'll read the three of them together because I think they will be similar. Will a HEPA filter be enough if a person is using a wood burner as a secondary heat source for part of the day? They use gas or oil furnaces about the other half of the day. And then the second question that aligns with the wood-burning stoves is we serve a lot of patients in the rural settings that use wood-burning stoves as a primary heating source. This information is interesting. Any suggestions on educational tips? Some of these patients are not as receptive to change. I think we've all been there.
So as I mentioned, I have been making a list of those questions that I get all the time. That's one of them. So, what do we do about people who, use pellet stoves or wood-burning stoves to heat? So, if you have high levels of air pollution outside, let's say, for example, with a wildfire and smoke coming into the area, you want them to go indoors, you want them to shut the doors, shut the windows, and then they're going to be producing particles with their source of heat. We don't know exactly, we can't answer the question now based on what we know. It's one of those that we're going to need to look into. I think the only thing that we can really point out right now is that under ideal circumstances, people should be using EPA-approved wood-burning stoves so that the emissions from those are minimized. I think intuitively, I would think that you could improve the overall quality of your indoor environment by using a high-quality HEPA filter, which is appropriately sized for the room that you're in. So I think it would be helpful, but I can't give you specific information on how helpful or how to make that decision.
No, but it's good to know that there are such things, not just the HEPA filters, but the EPA wood-burning stove that you mentioned, or pellet stove, because as we in home health, and I'm sure everybody's in the same boat that I was in, we have family members who are asking, what can I get for my family member? And they're looking for the non-traditional Christmas presents, and we're always talking about certain med boxes, certain items of clothing, non-slip flooring, getting rid of the rugs, things like that. But this is another element that if we do have patients who are using primary wood-burning stoves, pellet-burning stoves for the home, this is something that we can talk to the family about. I think we in home health have probably a better platform than most people in healthcare to work with our families and our patients on educating them on what would be better. It's not necessarily saying you must get this, but when they are looking for suggestions, we can guide them now, thanks to your information. So thank you for that.
Yeah, well, thank you. So with that comment, let me just add that EPA has information for people using wood stoves. I think they do evaluate particular products, and they have an opinion about what's good or what's better than others. There's also the BurnWise program, which provides some information to people about the use of wood, but the kind of wood you should use, and it should be dry, and those kinds of things. And then with respect to HEPA filters for improving air quality, California has a website where they have a list of approved HEPA filter air purifiers, because you don't want to use one that produces ozone. And so some of them come with carbon filters, which can take out some of the gases. That's a nice feature, but more expensive. You have the HEPA filters. You want one that's quiet, and then you do not want one that produces ozone.
All right, all of us out there, I hope you're taking notes. I'm writing down a ton of notes for myself. Thank you for that. The last comment, it's actually a comment that we have, and it's just thank you for this. This was very interesting. I never knew cholesterol levels were impacted by air quality. And I want to thank you for sharing all of this information, because I think all of us on here were not only privileged to have your knowledge being shared with us, but also pointing out things that we have just missed somehow throughout our learning how to care for our patients. So some of this, I think some of you have already known some of this, and it was a good review, but there was a lot of information that was new. And the multiple references to the studies, I think we all have our reading list available now for over the holiday break. So I will just mention, for those of you that are looking for CEs, we want to make sure that you get your CEs. When you download, you can click on this link on the slide, and it will give you the step-by-step flyers. Just make sure that when you do get to step number 3, in order to get to the location to get your CEs, you must click on Cardiovascular Health Course Catalog in order to find this course. That seems to be one of the biggest issues once you get into the university. Remember, all you have to do, you do not need to rewatch this webinar. All you need to do is complete a really short evaluation and a reflective question, and then you will have the approved CEs for nursing. If you have forgotten your username, please email us at hhqi@qualityinsights.org, and we'll be glad to retrieve that for you instead of you making a second account. And if we'll go to the next slide, this is where you will find the location of where to submit additional questions as you have them, and I'm sure that they will come up as you continue working with your patients. Please feel free to reach out to us at hhqi@qualityinsights.org, and we will be glad to contact our expert and get information for you. And with that, I would like to thank everyone for joining us today. We do hope that since this is the close of 2018, that you do enjoy the holiday season, and we will talk with everyone again in 2019. Have a great day, everyone.